Hello, I'm Dr. Daniel Kuritzkes, and today I'll be talking about clinical outcomes and therapeutics of COVID-19. These are my disclosures. I'm going to start with a clinical update since we're now 9 months into the COVID-19 epidemic, and it's a good time to take stock of what we've learned about the epidemic in terms of its epidemiology and risks for mortality in order to set the stage for my talk on therapeutics. This slide shows the cumulative incidence of COVID-19 cases and deaths as of September 9th. You can see that there were just short of 28 million reported cases of COVID-19 across the world, with more than 900,000 deaths, and in the United States alone, more than 190,000 deaths, with Brazil, India, and Mexico coming close behind. The United States has actually experienced two peaks in COVID-19. The first occurred earlier in the spring, as shown here, with a peak occurring at the very end of April. And we were misled by thinking that the incidence of COVID-19 was declining as cases began to drop. But this drop in cases was really driven by control measures in the states most severely affected at the time, particularly in New York, in my own state of Massachusetts. As you can see in these dashed lines that I've added, what was really happening was a dramatic decline in the northeastern part of the United States that masked a rapid rise in cases in other parts of the United States, particularly in the southeast and in the Midwest, and which led to the subsequent second peak that occurred throughout the summer and has now been falling off, but with many concerns that we are reaching a plateau of about 40,000 cases per day. In addition, we saw in the United States a huge peak in deaths in March, April, and May, reaching approximately 100,000 deaths by the end of May, but we've now had nearly another 100,000 deaths through the middle of September, with projections that we might reach 300,000 deaths by the end of the calendar year. The deaths have not been solely due to COVID-19. This slide shows the excess mortality that has been experienced during the months of March and April, during the period from March through June of this year, where the dashed line shows the expected mortality for the same period based on previous year's data. The solid black line shows actual reported deaths from all causes during the same period of this year. And this sort of slate or blue-gray color indicates the numbers of deaths due to COVID-19. This slim brownish orange line here represents cases suspected of being COVID-19 but not diagnosed. But you notice there's this big tan area, which is additional excess mortality not due to COVID-19 itself, suggesting an effect on death due to other medical conditions that could not be cared for appropriately due to the strain on the healthcare system. This slide just focused just on the top line here, gives some actual numbers, and here we are speaking just about the period from March to April. You can see that it would be expected to have about 420,000 deaths during this 2-month period in a typical year. And there were, in fact, more than 505,000 deaths, an excess mortality of 87,000. Only 56,000 of those were due to documented COVID-19, with another nearly 31,000 deaths either due to undiagnosed COVID-19 or more likely other causes, again, because people with heart disease, kidney disease, lung disease could not get the care that they needed in hospitals that were straining to take care of all of the patients with COVID-19. This study, now published in Nature from England, shows a multivariate analysis that analyzes a variety of risk factors, and what emerges overwhelmingly as the most important risk for mortality is age. Compared to individuals who are in their 50s who serve as the reference population, you can see that each additional decade of age carries a substantially increased hazard of death, with those in their 80s having a more than tenfold greater hazard of death compared to people in their 50s, and those in their 40s being relatively protected. Other important medical conditions that contribute to the risk of mortality include severe obesity, deprivation, malignancy, diabetes, and of course cardiovascular disease and pulmonary disease that are shown in the rest of this extensive tree diagram. Another notable factor that emerged in these analyses, and this is now from data in the United States, a study led by my colleague David Leaf from the nephrology division at Brigham and Women's Hospital, analyzed mortality in approximately 2,200 patients admitted to the intensive care unit with COVID-19 at 65 different hospitals across the country, and found that hospitals that took care of a larger number of patients with COVID-19 and had more ICU beds had a much lower risk of mortality than smaller hospitals with fewer ICU beds. I think this can be explained by two factors. One, experience counts. The more experience providers have in caring for patients with COVID, the better they get at providing that care. And secondly, size matters. The larger academic medical centers and other hospital centers that have a deep pool of personnel resources, whether it's residents and fellows or other attending staff and nursing staff that they can call on, clearly helped to mobilize resources that may have been unavailable at smaller community hospitals to cope with this pandemic. Well, let's turn now to talk about therapeutics per se. I'll cover three topics: remdesivir, corticosteroids, and convalescent plasma. Speaking first about remdesivir, this drug is an RNA-dependent RNA polymerase inhibitor with wide activity against RNA viruses, including against Ebola, SARS, MERS, and of course, SARS-CoV-2. In vitro studies show submicromolar EC50 activity against SARS-CoV-2 in cell lines and in respiratory epithelial cells. And animal models in the non-human primate have shown the drug to be effective against experimental infection with SARS-CoV-2. The first randomized clinical trial to demonstrate the benefit of remdesivir as compared to placebo was the ACT-1 study, which was a double-blind trial in hospitalized adults with COVID-19 pneumonia. Participants were randomized evenly between remdesivir or placebo, with the primary endpoint being the time to recovery within 28 days of hospital admission. This preliminary analysis was conducted after slightly more than 600 recoveries were attained, and you can see that overall, the participants who received remdesivir had a faster time to recovery compared to those who received placebo, and this was highly statistically significant. This advantage was most notable for patients who were receiving oxygen at the time that they entered into the study. There was less of an advantage for those who were not yet receiving oxygen, and really no difference in outcome for those who required either high flow oxygen or were already receiving mechanical ventilation. Remdesivir is relatively well tolerated. There was really no substantial difference in the most common adverse events seen between the remdesivir group and the placebo group in this trial. Now, two additional studies which were conducted by Gilead, the manufacturer of remdesivir, are the pair of SIMPLE trials, one done in severe disease and one done in moderate disease. The severe disease trial enrolled participants who had a significant oxygen requirement and oxygen saturation on room air that was less than 94%. These individuals all received remdesivir, so there was no placebo control. The comparison here is a 5-day versus a 10-day course of the drug. And you can see that overall, although there were some numerical differences, these differences ended up not being statistically significant, and there was no difference in mortality. If we drill down into some of the more specific outcome metrics, and these metrics are now commonly used in studies of COVID-19 using an ordinal scale that characterizes participants in terms of their need for supplemental oxygen, you can see that people who entered the study needing invasive mechanical ventilation, many still ended up on ventilatory support at the end of 14 days. Those who entered with the lower oxygen requirements did comparatively better, but there really aren't any differences between the 5 and 10-day groups. This study was also used then for another analysis that compared participants in the trial who received remdesivir to a comparison group that was enrolled contemporaneously at centers that were not participating in the actual drug trial, and found that there was a reduced mortality in the remdesivir group compared to the non-remdesivir group. That is, the recovery was about 75% in the remdesivir group compared to just under 60% in the non-remdesivir group, with 12.5% mortality compared to 7.5% in the remdesivir group. Now, it's important to emphasize this is not a randomized comparison. This is not a true placebo control group. It's a contemporaneous control group. The SIMPLE trial in moderate disease was a 3-arm double-blind study that did include a placebo. Again, had a comparison of 5 versus 10 days of remdesivir, and with a comparison of standard to care. Entry criteria here were an oxygen saturation better than 94%, and of course evidence of SARS-CoV-2 infection. This trial initially enrolled 600 participants with a primary endpoint of clinical status at day 11, and overall the 5-day arm showed a significantly greater clinical improvement as compared to standard of care, which was statistically significant. This slide, using that same ordinal scale, shows here compared to standard of care that the 5-day group had a statistically significantly better outcome in terms of all of the different ways of characterizing the study participants. This difference was not statistically significant for the longer treatment. However, at day 14, both the 10-day and 5-day courses showed the same statistically significant improvement. And then at day 28, the 10-day course still shows a statistically significant improvement, and the 5-day arm just misses being statistically significant. So overall, a clear significant advantage for remdesivir compared to standard of care. Well, let's talk now about corticosteroids. The reason to think about using steroids and other immune response modifiers in COVID-19 is that although the early stages of infection are dominated by viral infection per se and the viral destruction of respiratory epithelial cells, this sets the stage for a second pulmonary phase and later hyperinflammatory phase that's really predominated by the host immune response to the virus and subsequent immune-mediated lung injury. The recovery trial is a large randomized placebo-controlled trial of several different possible treatments for patients admitted to hospital with COVID-19. And more than 11,500 participants have been randomized to the various arms of that trial, several of which have now been completed and reported out. The hydroxychloroquine study had a negative result, as did the lopinavir-ritonavir trial. And I will talk about the positive results from the dexamethasone study. Several of the other arms are still ongoing. This slide shows the results of the dexamethasone study, which randomized, as you can see here, more than 4,000 participants to standard of care, which was a shared control arm across all the arms, and more than 2,100 participants to dexamethasone. The individuals received 6 milligrams a day of dexamethasone for 10 days. And what you can see is that overall, there was a statistically significant reduction in risk of death due to COVID-19 in the dexamethasone group. That advantage was most pronounced in participants who were sickest, those requiring invasive mechanical ventilation, and was also significant among those who required supplemental oxygen. But no benefit was observed, and the potential for harm, although not statistically significant, observed in those receiving dexamethasone who had earlier stage disease and not yet requiring supplemental oxygen. Now, a meta-analysis has been conducted of numerous studies of various corticosteroids, all of which were underway at the same time as the recovery trial, and these other studies ended up ending prematurely because of the convincing positive results seen from the recovery. And then the investigators banded together and undertook a meta-analysis that was published recently in JAMA and was really led by the WHO and forms the basis for WHO guidelines around the use of corticosteroids. What you can see here in this tree diagram is that all of the studies with the possibly, and all of people in all of the different risk categories show benefit of steroids. This included those receiving mechanical ventilation and those not yet ventilated, those receiving supplemental oxygen coming predominantly from the recovery trial. There may be some question about the role of vasoactive medications in this setting, but the numbers here are a bit small. Clearly a benefit regardless of age or gender, and whether people receive treatment within 7 days or after more than 7 days of symptoms. These data in aggregate have led to the WHO guidance on corticosteroids for COVID-19. The first recommendation being that systemic corticosteroids, whether dexamethasone or others such as hydrocortisone or prednisolone, should be used in the treatment of patients with severe or critical COVID-19, and this is a strong recommendation. In addition, there's a recommendation not to use systemic corticosteroids in the treatment of patients with non-severe COVID-19. That is a conditional recommendation. The evidence on which the panel bases this recommendation is with a moderate certainty of evidence is the mortality reduction of 8.7% and 6.7% in COVID patients who are critically or severely ill, respectively. Key practical issues for the use of systemic corticosteroids are that the dosing would be 6 milligrams daily of oral or IV dexamethasone, or 50 milligrams intravenously every 8 hours of hydroxycortisone for a 7 to 10 day period. Let me turn now briefly to a discussion of convalescent plasma. Convalescent plasma from survivors of COVID-19 infection may contain high titers of neutralizing antibody, and this approach to treatment has shown some benefit in managing avian influenza, H1 influenza, and MERS. Pilot studies and uncontrolled studies have suggested a possible benefit of convalescent plasma in COVID-19. A phase 2 open-label randomized clinical trial of convalescent plasma conducted in China at 7 medical centers in Wuhan enrolled 103 participants who were randomized evenly to convalescent plasma or standard of care, where the units of plasma were screened for spike protein specific IgG titers directed against the receptor binding domain that were 1 in 640 or greater, with a primary endpoint to time to clinical improvement within 28 days. In this small study, which is really a phase 2 trial, as I mentioned, there was no advantage of convalescent plasma overall, but in those with severe disease, there did seem to be a statistically significant benefit. And by contrast, in those with life-threatening disease, the sickest participants who were already intubated, there was no advantage. Joyner and colleagues have published in preprint form their experience in the expanded access program that was run from the Mayo Clinic in Rochester, Minnesota. They included several different analyses, which I'll just briefly summarize here. Looking at the 7-day adjusted mortality, here analyzed on the basis of whether the units of plasma had low, medium, or high titers of antibody, not necessarily neutralizing any, but just antibody as measured by an IgG assay. There appears to be a trend towards a greater benefit, a reduction in mortality among those who received the high dose or high titer plasmas. And that trend is still seen in the 30-day adjusted mortality, although these differences are not statistically significant. However, if you then also stratify on the basis of whether participants or recipients received plasma within 3 days of admission or more than 4 days or later, there may be a benefit in the high dose group for those who got the earliest doses of drug or plasma compared to those who received later. Again, just missing statistical significance. So I think the issue around convalescent plasma is that we still don't really have firm placebo-controlled data for a benefit, and we desperately need the results of the ongoing placebo-controlled trials. So let me end with this summary. The COVID-19 pandemic has resulted in substantial excess deaths in the United States and around the world. Remdesivir reduces time to recovery in patients with moderate and severe disease. Its use in early disease is currently being explored. Corticosteroids improve survival in patients with COVID-19 who require supplemental oxygen or mechanical ventilation, but should be used with caution in patients with earlier stages of disease. Convalescent plasma may provide benefit in patients with severe COVID-19, but we're still awaiting data from controlled trials, and at the same time, studies are just getting underway with much more specific approaches using monoclonal antibodies directed against the spike protein, and we eagerly await the results of those trials as well. So thanks for your attention, and I'll turn this back over to our moderator.